As far as treatment goes, we have a number of different FDA-approved options for our patients with ALK-positive non-small cell lung cancer. Frontline treatment options are shown here. So we have alectinib, which was first approved back in November 2017, brigatinib, approved in May of 2020, and then most recently we have lorlatinib, which was approved in March of 2021. And I'm going to go through a little bit of the data that led to the approvals shortly. There are some other ALK inhibitors. So it really started with crizotinib and also then ceritinib. And so I'll again be sharing data with you now that we have these other options available. I think the role of crizotinib and ceritinib is less clear. This is a summary of the phase 3 trials of first-line treatment with ALK inhibitors in ALK rearranged non-small cell lung cancer. So as I mentioned, it started with the Profile 101 study with the use of crizotinib, which was really the first ALK inhibitor. In this study, it was compared against chemotherapy. So it was platinum pemetrexed compared to crizotinib. And we saw a significantly higher response rate in those patients receiving crizotinib, which led to it being now approved as a frontline option for our patients with ALK rearrangements. Next came ceritinib, and this was studied in the Ascend-4 study. Again, in this trial, ceritinib was compared against chemotherapy, showed a significant improvement in overall response rate and progression-free survival. And then the later generation ALK tyrosine kinase inhibitors are shown here, alectinib, brigatinib, and lorlatinib. In these studies, the later generation TKI was compared against crizotinib, which had really become the standard. And what we're seeing is that there was a significant improvement in, again, overall response rate and progression-free survival with these later generation ALK inhibitors compared to crizotinib. So I wanted to just start with the Profile 101 study. So this was, again, a study that compared crizotinib to chemotherapy. And what you can see here is that progression-free survival strongly favored those patients receiving crizotinib compared to chemotherapy. No significant difference in overall survival was seen, and this is because crossover was allowed, meaning that those patients who were randomized to receive chemotherapy at the time of disease progression, they were allowed to go on to receive crizotinib. And so if that crossover effect is allowed, it can make it quite difficult to be able to tease out survival differences in the end. But based upon this data, the FDA did approve crizotinib as a frontline treatment option for our patients with ALK rearrangements in August 2011. As we started using crizotinib, we did find that acquired resistance to this drug was quite common. So the median progression-free survival on crizotinib was on the order of 7.7 to 10.9 months. So around less than a year, most patients would develop resistance to crizotinib. And so we knew we had to try to do better. So the ALEX trial looked at alectinib, which is a second-generation ALK inhibitor, and compared it against crizotinib. And again, it was compared in the frontline setting in our patients with ALK-positive lung cancer. And this is the 5-year data that was recently published, showing a continued significant survival benefit for those patients receiving alectinib compared to crizotinib. And so this has now really established alectinib as a frontline option for our patients with ALK rearrangements. And this is really the preferred option for many of us in clinical practice. When we look at the safety with alectinib, overall, it seemed that alectinib was better tolerated compared to crizotinib. And so this drug was approved in November 2017. It's important to point out that in addition to the overall survival benefit, that alectinib demonstrated an improvement in progression-free survival as well as in brain penetration. So I think that's an important point. So we know that patients who have ALK rearrangements are more prone to developing brain metastases. So it's always great when we have these newer drugs that can get into the brain better. And so, as I mentioned, alectinib is now a preferred frontline option. Next came the ALTA first-line trial, and this is looking at another second-generation ALK inhibitor, brigatinib, again comparing it against crizotinib in ALK-rearranged non-small cell lung cancer patients. Again, we're seeing here clear progression-free survival benefit. in those patients receiving brigatinib compared to crizotinib. No significant difference in overall survival. Again, this is due to the crossover effect. So once patients progressed on crizotinib, they were allowed to go on to receive brigatinib, which really makes it difficult to be able to tease out survival differences in the end. When we look at the safety, it's just important to keep in mind that brigatinib does have certain adverse events that we just need to look out for. Increased blood creatinine kinase levels were seen more frequently in those patients receiving brigatinib. Cough and hypertension were also noted more frequently. So just things to be aware of. And again, based upon this encouraging data, in May of 2020, the FDA did approve brigatinib as a frontline option for our patients with ALK-positive non-small cell lung cancer. And then finally, we have the CROWN study. So this is looking at the third generation ALK inhibitor, lorlatinib, again, comparing it against crizotinib as first-line therapy for ALK-positive patients. Significant improvement in progression-free survival seen in those patients receiving lorlatinib. Again, we're seeing a significant improvement with regard to time to intracranial progression, as well as cumulative incidence of CNS progression as the first event. So improvements there in those patients receiving lorlatinib compared to crizotinib. So based upon this encouraging data, in March of 2021, so just last year, the FDA did approve lorlatinib as a frontline option for ALK-rearranged non-small cell lung cancer patients. Again, looking at safety, lorlatinib overall did seem to have sort of, again, kind of unique side effects that need to be considered. So hypercholesterolemia and hypertriglyceridemia were seen quite commonly in patients treated with lorlatinib. And so this is just something that we are now monitoring for when we start patients on this drug. Edema was also seen more commonly, and then associated increased weight. Peripheral neuropathy and cognitive effects were also seen. So just, again, to be aware of these side effects and to really try to manage them as best we can. We have some strategies that we can use to try to overcome some of these adverse events.